at our content. What are we going to talk about today? We're going to talk about the treatment of wounds. We're going to talk about preparing wounds for healing. And one of the primary aspects of healing, other than your patient or resident's body, that's where healing starts, not with a dressing, but with the body. Wound hygiene is a component that where we need to start preparing that wound for healing. So today we're really going to dive into wound hygiene. We're going to talk a little bit about infection prevention and control, wound bed preparation, all of this, wound cleansing, all of this is in the wound hygiene construct. And then we're going to go into topical antimicrobials. And topical antimicrobials have a place in your stewardship, in your antibiotic stewardship. We're trying not to go to systemic antibiotics if we can. So please really listen to when we get to the part about the topical antimicrobials and how to use them. It's important to know how to use them also. These are the handouts that Jacqueline is going to be sending to you. And one of the things that's also in there that I've been putting together for all of our national webinars is a quiz over the content. So if you want to use these national webinars and the materials that we send you and the quizzes, you can literally use them if you're in long-term care as part of your plan of correction. Those surveyors love to see those quizzes and that your people dove into this information. They took a quiz, they passed the quiz. That's very meaningful for someone that is performing the survey process. So when we think about wound healing, it requires that the bioburden in that wound, it has to be controlled, either by the patient's own innate immunity, we all have innate inside of us immune system, or by the wound team, whoever's doing the wound cleansing, whoever's doing, even if you don't have a wound team, you need one. Every building, every hospital should have a wound team. Every home health agency should have people who know wound management, because this is not something that jumps into your head. It is something that takes a lot of energy to get this information and then to use it in our clinical practice. So the risk of wound infection, it's influenced by the interaction of three primary factors. That one of the first things to consider is that patient's health. Does the patient have adequate resistance to the microbial interference that's taking place? How healthy are these people? Some of your patients are healthy. They just went to get a total joint replacement. The system that's breaking down for them is the skeletal system. But everything else is still in place. Other people where they have 2, 3, 4 organ systems that are failing, they're probably not going to have a good innate immune system, and they're going to be at higher risk for infection. And that's part of your skill set, is figuring out who's at risk for infections when we have open wounds and being proactive with this. Do they have an intact immune system? What's the patient's overall health look like? What do the lab values say regarding that wound patient's organ system functions? The second risk for wound infection is the local wound environment. Is the bioburden under control? Is there blood flow to that area, particularly if it's in the lower extremities? And the third component of infection risk is the microbial burden, including the number, how many bacteria or whatever it is that we're looking at, the bioburden, what's the number, how much? The virulence, some bacteria is much more virulent and hard to clear than others, and then the phenotype of these infectious organisms. So it starts here with understanding, first of all, who's the host? What do they have going on? So you want to look at all the systems. You go back to your lab work. So consider host factors for infection prevention and healing impairments. You start with the body, not with a dressing. We start with the body. And we think wound biofilm. In the last 15 years, the whole construct for infection has changed and moved to the biofilm theory. And this is considered to be a complex community of different species of bacteria and fungi, which causes this subclinical wound infection. And we're going to talk about covert and overt, and then systemic wound infections. But you must learn what covert and overt looks like and how they behave, because that's where you start your topical antimicrobials. You want to know that this biofilm, it can protect itself from the host immune response. It's tolerant to antibiotics and antiseptics, and this biofilm reforms. If you knock it down with debridement, you knock it down with good wounds cleansing, with scrubbing that wound bed to help knock that biofilm down, it starts building within 2 hours, and between 2 and 3 days, that biofilm is completely reformed. That's why nurses, with every therapist, physicians, nurse practitioners, physician assistants. It doesn't matter what your credential is. If you're taking care of a wound, if you're doing that dressing change, you have to understand debridement and wound cleansing to do a good job. And that's what we're going to talk about today. And I want you to think about bacteria come in two forms. They come in planktonic where they're free floating. This is what our antibiotics by all these corporations that do all these wonderful tests on antibiotics and how the different antibiotics work on the bacteria. It's all done on planktonic bacteria. Well, that's not a biofilm. And so the antibiotics that we're giving, they work great in a petri dish, but they don't work great in the presence of a biofilm. This biofilm, it's these complex communities of bacteria, yeast, fungi. They're microbial cities is what they are. They adhere to solid surfaces. I just had an implant that I had to have a biofilm in my mouth scraped off my tooth implant. It happens in our total joint replacements. It happens in your pipes, in your water pipes. Biofilms are everywhere, but most of them don't cause infections. They create and embed themselves in this, what you see over here is this self-generated extracellular polysaccharide matrix. Again, neither antibiotics, oral or IV, or the host immunity will get through that biofilm's protective matrix. So this is one of the things that I want you to look at with me. And this is important because it's talking to you about the microbial states with this increasing microbial burden. And we're going to start over here with contamination. All wounds are contaminated. 100% of your wounds are contaminated at the time of wounding, but there's no host response. There's no delay in healing that you're going to see. However, as the wound stays open, now it's going to begin to start the bacteria, whatever's growing there is going to start to duplicate, and they're going to start coming together to form a relationship, so to speak. And this is colonization. So they're present, they're having some proliferation take place, but there's no host reaction, and the wound healing is continuing. So this is where everything is clipping along really nicely with your wound healing. And then we get to our local wound infections, and that's divided into two different concepts. Your covert, your covert here, and these are your subtle. These are subtle things that you're going to see. Then we have overt. And I'm going to come back to this at some point in time. So you want to be alert for these clinical indicators of a potential biofilm, where you have hypergranulation tissue, you have friable tissue, epithelial bridging. I'm going to go through all of this. So that's covert. Then we have overt. Covert is something you can't see. It's hidden, but it's there. Overt, these are your classic signs and symptoms of a local wound infection. Is your overt infection, your normal classic signs and symptoms with your erythema, your local warmth, the swelling, purulent discharge. This is where we're going to start using our topical antimicrobials, but there's certain construct that you must build before you even put your topical antimicrobials on, and we'll talk about that in just a minute. And if we don't do that, then we run the risk of this having a spreading infection where you start getting that induration, that hardness, spreading erythema further outside the edges of the wound bed. The inflammation is 2 to 3 centimeters and further outside the edge of the wound, crepitus. The wound breaks down, and then the wound can go systemic. So this is very, very important for you to understand this sweet spot right here. The sweet, sweet, sweet spot is over here where the wound is staying colonized. But if we get the local wound infection, subtle, which is your covert, or your classic signs and symptoms, overt, this is where you're going to really start working on that wound so you don't end up with a wound going to a systemic stage. And that's what we've just talked about. Here's your planktonic bacteria coming together. They're beginning to form a relationship. They're beginning to build up and exude that extracellular polymetric matrix. They're beginning to grow and during here, right in here, you're going to have those subtle signs and symptoms. And then over here, you're going to start having those overt signs and symptoms of a local infection. And then they disperse. They used up all their oxygen or all their food, whatever is going there. So, oh, we've got to go someplace where we have more resources. And that's when your infection starts spreading and it goes systemic on you. So our rationale for wound hygiene, the number of hard to heal wounds, it's increasing. And we have this tenacious biofilm. So what's important with this wound hygiene construct, one of the things that's very, very important is that you cleanse both that wound bed, the wound edge, and the peri-wound area. So I guess that's three places: the wound bed, the wound edge, and the peri-wound area. There needs to be debridement. If you do not have providers in your buildings, then you need your nurses who are trained. They're going to have to be RNs in all states except for Arizona. They can be an LVN in Arizona or an LPN, I'm not sure which one it is, to do some type of conservative sharp debridement, or you have your providers that can do conservative sharp or surgical debridement. You must have someone in your building that knows how to do debridement with sharp instruments if you're going to get some of the outcomes that you need, or you're going to have to send your people out. I would much rather you have skilled people in the building than having to send your people out to outpatient wound care. But if that's what you have to do, then that's what you have to do. We have to have debridement under certain circumstances. And then when you finish the debridement, the wound has to be cleansed again. Always cleanse after debridement. You don't want to leave anything behind that could make that infection worse or have any other debris left behind. So after we do debridement, mechanical, sharp, surgical, it doesn't matter what type, we cleanse that wound again. Then we put on anti-biofilm treatment. You can put on a solution of some type, maybe Vosh, something along that line, or you could put on a dressing. So you want to put your dressing on after debridement. And then also there's going to be times when the wound edges are going to have to be refashioned because they're starting to roll. You're starting to get epiboly. And then you're going to put the appropriate wound dressing on top of that wound. And in this case, what we're talking about is you're going to put on some type of antimicrobial. And this handout has been provided for you. So when we look at wound hygiene, it's fundamental concept, fundamental construct for all types of wounds. And you want to assume that all hard to heal wounds have a bio burden. Non-healing. Look at this slide. Non-healing should be regarded as a pathology, something stopping this wound from closing. And so we have to have the right tools. You have to have the underlying etiology correct. We don't always get the etiologies correct. You have to have your etiology correct, and you're going to manage that wound with the standards of practice. One of the things, if you're in long-term care, it talks about in the MDS, not in the MDS, that's not what I wanted to say, in F686, the skin integrity tag, F686, that's for pressure injuries. It talks about over and over and over that you are using the standards of practice. And it has some of the standards of practice, a lot of the standards of practice, but CMS doesn't keep up with the standards of practice. That's our job to do that, but they do have a lot in F686. So if you're in long-term care, be sure that, or you're at the DON, ADON, the educator, be sure you use F686 as a teaching tool for all of your new nurses that are going to be doing wounds in your buildings. Wound hygiene, including debridement, is necessary prior to application of topical antimicrobials to have the best outcome using these more expensive dressings. When we go to topical antimicrobials, we're usually having to spend more money, which is okay if we're going to get the outcomes we're going to get, but don't put those antimicrobial dressings on top of dead tissue. Do not do it. They can't get through the dead tissue to treat the viable tissue that we're trying to protect. So our components of wound hygiene includes vigorous cleaning every single time you do a dressing change. Every single time, even if that wound looks good. Now, if you're going to change a dressing 3 times a day, don't know why you would do that, but you might have a reason to. If you're going to do it 3 times a day, you might not do a thorough cleansing every single time. You're going to do some cleansing. But when you do your wound cleansing, it should include some mechanical debridement, at least, nurses. And if you have necrotic tissue in there, someone needs to be taking it out, and oftentimes it needs to come out with a cold hard steel. So when we do wound hygiene, we have vigorous cleaning, there's debridement, and there's the topical antimicrobials. This is your construct. It's 3 things. It's 3 things. Now, how you get there is what you're going to work out with your team. So we're going to talk about wound cleansing, which is a major component for wound hygiene. And here's the question, and I'm going to look in a minute to see if anybody said anything, and let's see what you say. How well, let me see, what do we got here? We have 50 people on here. So somebody answer me. How well do you think that the wounds are being cleansed in your building facility? What do you think? So just type in there what you think. Jacqueline will let me know in a few minutes when we get to a stopping place. So we're going to talk about wound cleansing. And do you think wound cleansing is taking place as often as it should and as well as it should as we go through this? So when we're looking at cleansing, inadequate cleansing is seen in all care settings. You can say you've got the best cleansing in the world, but you don't know what anybody else is doing. You only know what you're doing. unless you are doing competency and watching other people doing that process. So we have to decide, we all have to decide, are we going to clean this wound or are we going to anoint it? Are you going to bless it? Are you going to baptize it? Well, those are nice things to do, but that's not what you're trying to do. You're trying to cleanse it. So putting on that pink thingy and rinsing it, that doesn't get through the biofilm. Spraying on anything, unless it's an antimicrobial, does not get through the biofilm. So we are under cleansing our wounds. And this saline isn't going to cleanse it and has no effect on the microbe. Saline doesn't. We'll talk about that in a little while. So when you use wound cleansing, you want to use fluids and our devices to remove loosely adherent contaminants and devitalize materials from the wound surface and the wound edges. And look at this, cleansing of that peri-wound is considered part of a complete dressing change. Cleansing of the peri-wound, the edge of that wound, and then that peri-wound area for as far out as you need to change to cleanse it, because that's where the bacteria is. A lot of the bacteria is on the edge and on the wound skin, and it's getting into our wound and causing some of our infection. So that's why the recommendation is that we cleanse the peri-wound skin at least 10 to 20 centimeters away from that wound edges. Further, if you're seeing evidence of contaminants or scales, if you see scales, those scales have to come off. The scales have to come off. So you want to use an antiseptic wash or a surfactant. We're going to talk about surfactants in a minute, if possible, to help avoid cross-contamination. And often the bacteria that infects that wound is on the peri-wound area and the local skin. Please remember that. Even if the wound doesn't look like it's clean, look at this wound. Isn't that beautiful, beautiful granulation tissue? This is what gets us all excited, is this granulation tissue. And the reason I'm pointing over here is that's where your monitor is that I'm speaking to. Your slides are up over here. So this wound that you see, it looks beautiful. You're gonna think, I don't need to cleanse that. Yes, you do need to cleanse that. Even if it doesn't look like it has a biofilm, like this one on the top, of course you're gonna cleanse the one on the bottom. But I hope you do some scrubbing with that also, unless you're going to use sharps, because your antimicrobial sitting on top of that slough is not going to do any good. So part of wound bed preparation is which I'll tell you about in just a few minutes. It helps to remove the surface debris, reduce your bacterial load, and mitigate that biofilm activity. So the challenge that we have in wound management and wound medicine, if you're a provider, is how are we going to clean this and what are we going to clean it with? So when we look at our biofilm-based wound management, it starts with wound hygiene. Even if that wound doesn't look like it has biofilm, cleansing needs to be a priority, and you want to vigorously clean these wounds to the extent possible. Debride when necessary, including the edges, and continue with maintenance wound hygiene with each dressing change, This is a wound cleansing solution options on page 9, table 28 of the International Wound Infection Institute, the IWII. This is one of the articles that has been provided for you, and I'm not going to be able to go through. We don't have time to go through every one of these. So what I did in this document is I did give you a few pages to go back and look for you and your wound team to look at, to see if you're not satisfied with your cleansers right now. This might give you some other ideas. Surfactant stands for surface active agent. Surfactants, when you wash your hair and you get all those bubbles, you always want to be sure you get lots and lots of bubbles, because it's the bubbles that are surface active agents. All those bubbles, you want to wash your hands when you have C. diff in your buildings. You're supposed to be doing actual hand washing, not the alcohol-based hand rub. You're not supposed to do that when we have C. diff, but you got to go have those scrubbing bubbles, because that's what loosens the debris that's holding the bacteria in the wound bed, is those scrubbing bubbles, surface active agents. They're very, very important. So the commercial cleansers, we do have commercial cleansers that enhance, and they have the surface active agents in it, the surfactants. The surfactants breaks the bonds of foreign bodies in that wound surface, and the strength of their chemical reactivity is proportional to their cleansing capacity and toxicity. And there's a reason for saying this. That is because we have some people that do not understand that a skin cleanser is a different type of product than a wound cleanser. Skin cleansers are cytotoxic. You know the bad word for cytic. So cyto is cellular, toxic. So skin cleansers are cytotoxic and damage and kill the cells that you need for wound healing. So you want to be sure you don't use skin cleansers in wounds. You have to use wound cleansers. Saline has no impact on microbes or the biofilm. Portable water doesn't cause infections from this research from very, very long time ago, but again, has no impact on the microbes and the biofilm. What the water saline will do is you have loosely, say you have a road rash, you have loose contaminants in that wound bed that you want to rinse out the force of the water or the water loosening whatever dirt or debris is in there. You could use water for that, but it's not going to decrease the bioburden per se. This slide, the reason this slide is here is because there is a device, very expensive device, and because we're not doing CE here, I get to say what I want to say. It's called the Moleculite. It's a very expensive device. It's a fabulous device. So what we're teaching you here is, you might think, oh, I'm cleaning that leg. This leg has to be cleaned up. When you look at this leg has to be cleaned up. This is a nasty leg. It has to be cleaned. We can't leave it like this. So they shine the light on it. All this green stuff is Pseudomonas, and the red stuff is bacteria. So we have a lot of bacteria and microbes that are in here. So the nurses clean it, clean it, clean it. Look at that leg. That leg looks so good from this to this. Oh my, it looks so good. But here's what it looked like before cleansing. This is what it looks like after. Look at all the bacteria that is still there. So the nurses went back and they cleaned some more, cleaned and cleaned and cleaned. And this is where they got. This is to show you that we're not cleansing well for the most part. Scales have to be taken off. And we recently had a building that got an F tag because the scales weren't removed from a venous leg ulcer. And the surveyor said that skin was in jeopardy of more breakdown and that it looked dirty. And the patient said that they were embarrassed about the scales being on their legs. And they got an F tag. F is a federal tag if you're not in Louisiana, if you're not in long-term care. F is a federal tag. That's what it stands for. F stands for federal. It also stands for failure. And it means that we're going to have probably have a surveyor give us a citation. And then we have to do a plan of correction. We have to do all kinds of things when we get citations. Scales. Now, the reason I'm saying this to you wasn't because they got an F tag as much as it is. Look at this scale over here. This scale right in the middle came from this leg. They flipped it over. What do you see? Look at all the infection under the scale sitting on the skin. Oh, and by the way, shaving cream is often used to soften and loosen scales on the legs, particularly from venous insufficiency and maybe lymphedema. It's very hydrating and it has emollient properties. Shaving cream does also. So this is, again, this is a dried out zinc-based product that's on here. And we're seeing people, we're seeing some of our teams leave this on and just put something on the wound here, but leave all of this on here. It has to come off. All of this has to come off. It's part of your cleansing. It's part of the cleansing. Now, I want you to watch as they're doing some cleaning here with this gloves. They're doing cleaning up this foot. The foot has a lot of gunk on it. It needs cleaning, but they're using gauze and they're using it under the Moleculite. This is another training opportunity with nursing particularly. And what you see as you look at this is you see the bacteria, whatever is glowing there, is now going on the gloves. It's being put on different parts of the gauze. They're just folding the gauze over and over and over and putting the stuff back on the foot. You have to change your gauze. Nurses, one gauze. Physicians, PAs, NPs, one gauze for something like this isn't enough. You're going to need to change your gauze and change it frequently when you're doing this kind of work. So gauze scrubbing does have associated discomfort. It's less effective on the bacterial load than monofilaments. So we do have something called a monofilament. I'm not seeing it. I was looking to see if I had one here, but I don't. It doesn't hurt the way gauze does. So if you're interested in that, let us know. The gauze is less expensive, of course, and we all have to watch our finances for our buildings. You might want to use a topical analgesic, especially if that person has a low pain tolerance, and to change the gauze often as you clean. Don't keep using the same piece of gauze, and you might even have to change your gloves. So when we look at wound bed preparation falls in line and dovetails with wound hygiene. And this is the framework for about 25 years. Wound bed preparation has been our framework for wound management. So you're looking at the tissue in the wound bed. Is it viable or non-viable? Is it granulation tissue? Is it slough? Is it eschar? So you're looking at the tissue. The T, we're doing an acronym. TI is your infection or your inflammation. All wounds get stuck. Chronic hard to heal wounds get stuck in the latter phase of the inflammatory phase and won't move on to the proliferative phase, they stay in the inflammatory phase. And that's also when where you begin to see some of your infection, but you see infections in the proliferative phase also. So TIM is moisture regulation. We're using dressings and negative pressure wound therapy to help us with moisture regulation. So TIME, the edges of the wound, time. 80% of your reepithelialization comes from the edge of the wound. Sometimes you'll have epidermal cells that come up in the middle of granulation tissue. That means that you have a partial full thickness wound, that a hair follicle is still in place and down in the dermis, at the bottom of the dermis, and that keratinocyte, that epidermal cell that covers the top of the wound, is coming up that hair follicle and getting in the middle of that granulation tissue. And every one of those little epithelial islands, they're called epithelial islands in the middle of that granulation tissue, are precious to you because you're going to get more resurfacing, more epidermal resurfacing and wound closure when you have these islands. Now, when you have those islands, you have partial and full thickness. I'm on a tangent, partial and full thickness, and we always call our wounds the worst depth. So if you have granulation tissue, you have a full thickness wound. If you have keratinocytes, there's a partial component, but we have to call it full thickness. You call the wound the worst of the thickness. So that would be full thickness if you have granulation tissue in the wound at all. And then the periwound skin, again, the periwound skin harbors the bacteria, so you want to keep that clean. Now we're going to talk about debridement, and we're going to talk about the step down, step up concept, and people get confused about this. If you haven't heard about this, you're going to hear it more and more, particularly if your provider groups come in, because they should be using this construct as wound medicine providers for how they do their care and how they're working. So I wanted you to know this too. We start with aggressive debridement. And we're going to come back to this, but we're talking about debridement right now. So this is where we start with debridement, and you need to know what to debride, you and your providers. I have the honor, the privilege, and I'm truly humbled by this. I get to teach every credential there is from our physicians, nurse practitioners, physician assistants, all the way through to our CNAs and everyone in between. And I'm grateful for this. With that said, what to debride? You got to debride your necrotic tissue, slough and eschar, because, and we'll talk about this in a minute, different credentials allow different debridement depths. And we'll talk about that in just a moment. Epibole means rolled edges. Here's epibole right here. Anyone who has pierced ears, you have anything else pierced, I don't want to know about anything below your neck pierced. I don't want to know. Thank you very much. Hypergranulation tissue comes up above the edge of the wound. This is a covert infection. This comes under your covert infection grouping. And then here is your rolled edges, your epibole. You have pierced ears, you have epibole, anything that's piercing. We have a hole, but we don't have a closed skin in that area. So epibole. And this epibole all around this wound, the wound is granulating very nicely. A provider is going to have to come take off these rolled edges because this is viable and non-viable tissue. I'm a physical therapist and I can do conservative sharp debridement. My RNs can do conservative sharp debridement if they've been trained. In some states, they want you to have a credential, an accredited credential as a wound specialist RNs. In some states, you don't have to. Oh, and I don't have to in Texas because I can do conservative sharp debridement. So that's what we're going to be doing. And but this, when you do epibole, that needs to be a provider. Can't be a physical therapist, cannot be an RN. It must be a nurse practitioner if you're in the nursing arm of your credentials. Callus formation has to come off, abnormal or infected tissue. Sometimes providers have to take out infected tissue or infected tendons or different things that are going to be infected are going to have to come out. Exposed dead space has to happen someplace. Hypergranulation tissue, again, that's your covert infection taking place there. Biofilm, you can't see it, but you're going to take it out. And then non-viable anatomy will have to come out. Muscles, tendon, bones. There are times, I just wrote Pamela's Pearl today, and it was on chronic osteomyelitis is what the Pearl was on. By the way, Jacqueline, why don't you just, as a lagniappe, I'm from Louisiana originally, lagniappe, a little bit of extra. Why don't you put Pamela's pearls in there for them? It's an important pearl for you on osteomyelitis. So debridement is an important treatment against strategies. It doesn't remove all the biofilm. Some of that bacteria is embedded down in that viable tissue. And debridement can't be used alone. We have to do repeated debridement because that biofilm is regrowing. It starts regrowing in 2 hours and it's fully reformed within 72 hours, within 3 days. You want to have effective topical antiseptic application within this time-dependent window. Immediately after debridement, start your topical antimicrobials. Make that your first part of your dressing that's in contact with that wound bed will be your topical antimicrobial. Studies suggest that there's this window of opportunity for biofilm prevention when we do debridement. We open that wound up. And now you have the ability for your topical antimicrobials, even antibiotics. If you're trying to treat someone systemically with antibiotics, and we have some providers that do both topical antimicrobials and systemic antibiotics. So that you have up to 24 hours after the debridement of that biofilm to have an increased response with your systemic and topical antimicrobials. This is important. This is important. Now, our ladder of debridement, when we look at debridement, the different types of debridement, this isn't every single type of the debridement. This is most types of debridement. You have to have certain credentials. You have to look at the invasiveness of that debridement option, is particularly if you're using cold hard steel, if you're using scissors or curettes, the skill set of that person and the setting that we're in. So when we look at this, there it is. Okay. So autolytic debridement. Autolytic debridement is dependent on the health of the person's body. So in some care settings and in older people, especially, autolytic debridement doesn't work as well. Another type of debridement that supports autolytic debridement, and it's not exactly debridement, but it's called osmosis debridement, and that's using honey. Honey actually helps with a moisture shift that takes place and supports the autolytic debridement process. And honey is also antimicrobial. And that would go, I would put honey under the autolytic debridement, or you can use a dressing. Then the next one is your enzymatic debridement using collagenase. We do have bromelain, which is a pineapple enzymatic debrider, but the problem with bromelain is it burns. So we're not using that. The care setting that we're in most often is the post-acute care setting, home health and long-term care. So we're not using bromelain on our patients. Now, if you have a patient that has a diabetic foot ulcer and they have they're completely insensate and you want to use something like bromelain, it works fabulously. It really debrides that hard stuff fast, even eschar, which collagenase doesn't do. Collagenase is a wonderful enzyme, and that's what this is, enzymatic debridement, collagenase. Then we have our maggots. They are sterile maggots that are medical grade maggots, homegrown maggots. It doesn't matter. They both do the same thing, whether they're free range maggots or they're medical maggots. And that is they secrete collagenase out of their little maggot mouth. The same thing that's in our collagenase tube, but it didn't come from maggots. If you ever want to know how collagenase is made, let me know and I'll let you know. Then we have our mechanical debridement, which you just saw some scrubbing. It wasn't mechanical debridement that was taking place. And this is using the monofilament pad. This is pulse lavage with suction is another method of doing debridement and cleansing a wound and upregulating a wound. Low frequency ultrasound, which is contact. This is contact low frequency ultrasound, usually done in outpatient wound care centers. Although I am hearing that there are some provider groups that are starting to take low frequency ultrasound into the home health and into long-term care. You're sharp using your scalpels or your curettes or your scissors. Sharp, conservative sharp is what physical therapists and nurses that are not nurse practitioners can do. Conservative sharp debridement, and we remove non-viable tissue only. My Practice Act in Texas even states that I can do this. However, one of the reasons that it should be only the physical therapist or only the nurse doing sharp conservative debridement is debridement requires that you do assessment the entire time you're doing it. You're assessing for pain, you're assessing for the type of tissue, you're determining what type, how much to take out, you're determining what's safe and what's not safe, and all of that is assessment. Our LVN, LPNs, and our PTAs by licensure, not by knowledge, not by intelligence, by licensure, are not able to do these things. I am not able to do surgical debridement by licensure. Not that I don't know my anatomy and physiology and all the other things that I need to know. It's licensure. So we have to stay within our license. Your license is not a suggestion. It's the law under which we give our care. And we can lose our license and lose our livelihoods if we don't stay within our law. So surgical with scalpels are also hydrosurgical that you'll see sometimes in outpatient or the OR that removes viable and non-viable. That's the thing about surgical debridement. Our PAs, our nurse practitioners, our physicians can take out unhealthy, viable tissue also if they need to. Sharp debridement does not allow us to do that because we can't take out viable tissue. So the overall importance of debridement, cleansing and debridement, they're critically important to prevent patients from having extended periods of non-healing or non-viable tissue that causes this inflammatory response. And these inflammatory mediators, your matrix metalloproteases, become a problem in that wound bed. The delay in removing non-viable tissue suspends healing. It suspends your healing and increases your risk of infection. Urgency for removing non-viable tissue safely and thoroughly should be part of every wound program in every facility. Part of this urgency is driven by our recent knowledge regarding the formation and the effects of biofilms in wounds. And you can't look at a wound to determine if you have a biofilm present. We're not magic. We don't have magic eyes. I'm not Superwoman. Well, I am in some ways, but not in that way. And you want to assume that there's a biofilm in every hard to heal wound. Now we're going to transition to topical interventions for bioburden management. And you've been provided with this International Wound Infection Institute. Do we need to take any questions or anything, Miss
I
Jacqueline?
was I was just gonna say that was perfect timing because we had a good question from Jennifer
Okay.
about debridement. She
Okay.
said, "Are you seeing any pain tags for facilities using mechanical debridement, Debrasoft monofilament, or Zonix vibratory tool use for wound hygiene?"
I haven't seen anything specifically for pain tags, but you could certainly get a 697, which is your pain tag. If you if the surveyor's following you and they see the patient grimace, or if the patient tells the surveyor that they have pain, maybe even just a dressing change, they have pain in dressing change. So using some of these other tools that you're talking about, the monofilament, what else was mentioned? I saw monofilament, which is Debrasoft, yeah.
Mhm.
Zynex vibratory tool. Some of these vibratory tools for wound hygiene literally decrease the pain. Ultra Mist is one of those tools that you can use to help upregulate some of the cells for wound healing. It's a magical device. And it literally, it's ultrasonic. And for some reason, that ultrasound decreases the pain response. But that was a great question. Thank you.
Great.
Anything else, Miss Jacqueline, that we want to look at right now?
No, that's it for now. Just a reminder to everyone, please, if you have any questions at all during the session today, post them in the chat and we'll be glad to answer them. Go ahead,
Thank
Pamela.
you. Thank you, Jacqueline. So this International Wound Infection Institute is a great resource for infection control assessment and treatments for wound management. So now I told you we're going to go back to covert and overt. So we looked at this. We talked about all wounds are contaminated. All wounds become colonized when they stay open. Now we're going to talk about, be alert for the clinical indicators here again. So here you go. Signs of your covert local infection, hypergranulation tissue. There it is, bleeding, friable tissue, which is happening there. Epithelial bridging is happening over here. Increasing exudate. That's another sign. All of a sudden, they have a lot more exudate coming from your wound. Now, you'll get more exudate coming from your wound right after a sharp debridement, a surgical debridement, especially. That creates the inflammatory process and puts the wound back into the early part of the inflammatory process, which is what we want. But when you haven't done anything, and all of a sudden you have a lot more exudate, that's usually a sign that your bioburden is increasing. Delayed wound healing beyond expectations, increased odor. Your wound bioburden is increasing, and increased pain. Increased pain. So as you look at all of these over here, all of these have a local infection, a covert local infection. And then your overt signs is your erythema, that local warmth, swelling and induration, the purulent or increasing drainage. There's that drainage again. Wound breakdown and enlargement, new or increasing pain, and increasing malodor. So this is cellulitis in a leg, in our leg, and here's cellulitis. That foot looks like it's just going to blow up. Yes. Now, I do want to mention this because we're talking about antibiotic stewardship also, using topical antimicrobials in conjunction with or as an alternative until you decide what type of systemic antibiotics you want. But to decide, oftentimes our providers start empirically. We get broad spectrum antibiotic at first. We know we've got an infection, so they'll put on broad spectrum. In the meantime, you've taken a culture. The gold standard is a punch biopsy or a tissue biopsy. where you take viable tissue, never dead, never necrotic. You take viable tissue and you figure out which drug the bacteria are going to be susceptible to. So you want to get the right drug for the right bug, for the right person, for the right amount of time, and that requires a biopsy. You can use if anybody still uses cultures to get your antibiotic stewardship information, please put it in the chat and I'll come back and talk about cultures. These are being done by providers. If you're doing a punch biopsy or excisional biopsy, shave biopsy, you're usually being done by our providers. If you're doing a culture, you need to be using the Levine technique. And if y'all want me to talk about that, let's come back and I will. So your topical antimicrobials, these are your antibiotics, your antiseptics, your antimicrobial dressings, and some key terms that you want to have in your mind about this is important. So an antimicrobial is an agent that kills or inhibits microorganisms such as bacteria, fungi, and viruses, including antibiotics, and that's not what we're talking about right now. Antiseptics, we're talking about that, and antimicrobial wound technology such as silver or PHMB. So this is your antimicrobials, and we're going to be talking about antimicrobials. So your antiseptic is a topical broad spectrum antimicrobial used on living tissue. Antiseptics go on living tissue such as the skin, in wounds, or in the mucosa to reduce the microbial burden and to help prevent or control local infection. An antibiotic, of course, is an antimicrobial that targets bacteria and is the only class used systemically, which will be oral or IV. Now, we do have some topical antibiotics in wound medicine, but they're limited due to the risk of resistance and allergies. So we want to be very conservative about using our topical antibiotics. And then disinfectants, that's not what we're talking about here. Disinfectants is for inanimate objects and equipment for cleaning it. So that's not part of our antimicrobial umbrella for what we're talking about in wounds today. Now, we talked about this is your step down, step up concept for hard to heal wounds. So we just did and this has to do with our debridement. And after you do your debridement, then you're going to put on your topical antimicrobial. So that's where this is. Empirical, topical, antiseptics, and systemic antibiotics. You might put your systemic antibiotic on until you get this information next, which says to manage the host factors that such as offloading, compression, their diabetes, and especially in long-term care, I'm seeing diabetes is not managed at the level that they need to. If your blood glucose is over 200 milligrams per deciliter, protein synthesis stops. So if you're in long-term care, look at your blood glucoses. They're very important. So you start here. So your first 4 days, this is what we're doing. And then you're stepping down to the next 5 to 7, you're looking at the inflammation, you're determining if you need to continue debridement, and you always want to, again, personalize that topical antiseptics and continue the management of the host factors. All of these talk about continue management of the host factor, continue management of the host factor. Are we managing the cardiac disease at the level we need to? Are we managing the diabetes at the level we need to? Are these things being managed that can be managed? Sometimes you get to a tipping point with these organs and there's no bringing them back. You need to know that too. That's going to be determined by your lab values. Your lab values are going to tell you that. So deciding how to use antiseptics and antimicrobials, you're going to start with a 2-week challenge. So you're going to use these antimicrobials for maybe 2 weeks, and then you're going to come back and reassess. It could require up to 4 weeks. So you go back, you do 2 weeks, maybe it's just moving a little bit. So let's do more debridement. Let's make sure they have good nutrition and hydration on board, looking at the host factors, and then maybe do 2 more weeks. So I wouldn't do more than 4 with topicals without a good reason. If your wound's not getting better after 4 weeks, then you need to go back and really do a thorough patient assessment. And you might want to consider alternating your antimicrobials. Maybe you do 2 weeks of one antimicrobial and think, okay, that's a little bit better, but how about if I change to this antimicrobial? And you want to discontinue these antimicrobials, topical antimicrobials, when they're no longer necessary. And we don't use them prophylactically unless we don't use topical antimicrobials unless that person is at high risk for an infection. Then I might use topical antimicrobials. I would not use antibiotics, particularly not in the long-term and home health care setting, but I would use topical antimicrobials and I would change it after 2 weeks if I needed to. So these are just examples of some of the topical antiseptics with variable ingredients. Here's your methylene blue, gentium violet, dressing. Here's your silver. Silver comes in many forms. Now, it says antibiofilm activity. Antibiofilm activity. Antibiofilm activity means they're not moving, they're not dividing, they're not growing. The biofilm isn't growing, but it's just staying there. So that's what silver and the methylene blue do. Then we have cadexamer iodine literally gets through the biofilm. And unfortunately, our buildings won't buy this. I understand it costs more money, but those infections ending up costing 10 times more money if the infection gets away with this. So, you have to use your critical thinking skills to determine, am I going to spend a little bit more money here so that I don't have to spend all that money and risk rehospitalizations. We don't like rehospitalizations in long-term care. Here's PHMB, which again is a biofilm disruptor. Here's medical grade honey, again, antibiofilm activity, and it also helps to support the autolytic debridement process. This is DAC, dialkyl carpamyl chloride. It's a pathogen mesh binding, and I was asking one of my nurse practitioner friends that has a whole group of nurse practitioners in the Missouri area. I said, do y'all use that? She said, no, we don't use it, but one of our wound clinics loves it. So we do have people that are still using DAC, dialkyl carpamyl chloride pathogen mesh binding. So your topical antimicrobials, this is betadine that was put on a foot with fungus. You would never put betadine in a wound, even diluted. In most cases, you're not going to put betadine in a wound unless maybe you're doing some type of palliative wound care. But they couldn't get rid of this, couldn't get rid of it, could not get rid of it. They tried everything. And so finally they just poured betadine on it. And sure enough, it finally cleaned up that fungus. They didn't have any open wounds. But the issue is when you're looking at iodine, your betadine, this is broad spectrum antimicrobial activity. It is, but it's cytotoxic to the cells that we need for wound healing, including our granulation tissue when it's at the higher concentrations. So there is a method for delivery of this, and it's your cadexamer iodine or your polyvinyl alcohol dressings. These are delivery dressings. So cadexamer iodine, I just showed you that. That was this one, your cadexamer iodine. Anecdotally, the betadine dries it out. Now, heel pressure injuries. If anybody uses this to paint your heel pressure injuries, please let us know. I love it when you paint your heels with those Escar, stable, hard Escar. That povidone iodine, that betadine, will dry that out, and so that it won't begin to break down. It'll keep it stable. Say this person is an elder. They have decreased blood flow. They have a peripheral arterial disease, significant peripheral arterial disease. They have a heel pressure injury that got with just a little bit of pressure. It wasn't even there. That heel wasn't even there for 2 hours. But they have such compromised blood flow that the skin could not take 2 hours without that heel being off. So they get a heel pressure injury. They have no functional goals. They're not going to walk anymore. They're not going to get out of bed. They're not going to wear shoes. So paint that wound with betadine if you'd like to. But here's the caveat. Someone has to look at that heel every single day. That's one of the reasons I like heels being painted, because somebody has to lift up that foot and look at that heel every single day. Topical antimicrobials, again, this is your cadexamer iodine that does penetrate the biofilm. So we have our topical antimicrobials, your polyhexamethylene biguanide. It's commonly used in negative pressure. We have the research that shows significant reduction of MRSA. And the reduction of MRSA was only demonstrated using PHMB. Again, they did some research. Saline solutions failed to reduce the MRSA counts. This is hypochlorous acid. I use this. I'm on Amazon reorder. Every month I get one of these. We use this a lot in our household for different things. It fights bacteria, viruses, and inflammation, and it gets through the biofilm. Now, if you're using it in the bottle, you have to put it on gauze or on your dressing and leave it there at least 5 minutes. At least 5 full minutes. Putting that on and then just putting your dry dressing on top of it, you're just going to wick your dry dressing up, the hypochlorous acid up. So you want to make sure that you leave it in there so it can do its job and disrupt that biofilm. This is amazing stuff. Dakin solution, diluted hypochloric bleach. If it's at higher concentrations, it may harm healthy cells. Short-term use is okay for say you have somebody on palliative care and you want to use your Dakin solution, but wound healing's not your goal. Comfort care is, and that wound is smelling. You can use Dakins. But if you're absolutely, and you can use it at full strength Dakins, there is one that's at an eighth strength Dakins that you can also use for short term in wounds, but it's an eighth strength. You have to really decrease its uh, how strong it is. This is our hypochlorite skin and wound cleanser. This is set up to do both, and it does disrupt the biofilm. I see this used some, not a whole lot. It's wonderful against wound odor also. So highly recommend that. Your acetic acid is vinegar and water, and it's effective against odor and Pseudomonas. You know that sickly sweet Pseudomonas smell. This is one of the things you can make up your acetic acid vinegar solution, and you can use that to help you also when you have odor. Particularly, it's effective against gram-positive and gram-negative, including Pseudomonas, where you have that sickly sweet smell. Revive is something that our providers have started using, and it has surfactant in it, so it assists with the autolytic debridement. It has broad spectrum antimicrobial activity, and you can leave it on for up to 7 days. We were having trouble. Some of our buildings weren't changing their dressings the way they needed to, and we had to figure out how we're going to take care of this. I wish they would be strict the way my friend Amy is, and if they don't change the dressings appropriately, Amy gets on them, and that needs to happen because you can't miss the dressing changes. Not when you're trying to prevent infections or wounds from getting infected. We have to do the dressing changes and cleanse those wounds appropriately. Copper dressings are also something that has come in recently that might be appropriate. And so what I did for you, you have to decide which dressings you're going to use. You might use a durable medical equipment company that can help you with that also. But in that document on the International Wound Infection Institute, it talks about some of the different types of medicated and non-medicated dressings that you might use in wounds. So deciding when to use these antiseptics or antimicrobial dressings, most healthy healing wounds don't need it. The patient's body can take care of this. Despite the lack of high certainty clinical evidence of efficacy in hard to heal wounds, judicious use may be appropriate in preventing wound infection in high risk patients. You know someone has an autoimmune disease. You know they have an immunity issue. They have a wound now. Maybe prophylactically, you need to use some topical antimicrobials, particularly if you start seeing those subtle changes in that wound that we talked about. Go back and look at that sheet that I showed you, because you're going to have that. So we want to prevent wounds in high-risk patients if we can. You want to address the signs of that covert, those subtle wound infections, and you want to manage that overt spreading wound infections as an adjunct to systemic antibiotics. So you might choose to do topical and systemic at the same time, particularly if someone is at higher risk for infections. So topical antiseptics and antimicrobials should be applied following sharp or mechanical debridement. So guidance regarding the use of topical antimicrobials: don't treat colonization, treat the clinical change. Colonization, it doesn't need anything. Prophylactically, you want to treat the things such as increased exudate, increased odor, increased pain. The stalled healing. Stalled healing is a pathology. It's been healing nicely and it stalls. There's a problem. Don't wait for the stall to stop stalling. Intervene when it first stalls. You see that friable, especially friable granulation tissue, and new slough. New slough is a sign that you've got a problem. Silver, if you're going to use silver, it's a reset button. It's not really great, we're finding out, for long-term microbial control, maybe for short-term. And also we're learning that there may be impairments to reepithelialization when we use long-term silver. Iodine is great when you need antimicrobial plus slough or exudate control. Honey's a strong option for odor plus moist wound healing, and it does help with autolytic debridement. So you want to always pair your antimicrobials with a real fix, and the real fix is addressing the etiology. Are you doing compression the way you need to for venous insufficiency and lymphedema? And I'm telling you, it's not happening in long-term care the way it needs to. I think the place we do it the best is actually outpatient wound care centers. Maybe acute care, because they usually have good wound nurses in acute care. Let's see, what else did I want to tell you? Oh, so address the etiology. No antimicrobial dressing replaces repositioning or support surfaces for your pressure ulcer injury. No antimicrobial dressing is replaces appropriate compression for venous leg ulcers. And please, please, please do not use TED hose for compression for symptomatic edema. TED hose are dangerous. They are only for people who are bedbound and who are at risk for deep vein thrombosis. TED stands for thrombo embolic deterrent. It is not to be used for edema. It's not even woven correctly to take care of edema. No TED hose. The only thing that's for is for people who are bedbound in the bed and are at risk for deep vein thrombosis. Offloading for ambulating patients with diabetic foot ulcers, debridement for slough and biofilm for all wound etiologies, and we cannot forget that perfusion assessment for ischemia in the lower extremity. Always assess for vascularity. When you have a heel pressure injury, first thing you do is you get vascular studies to find out if you're going to have a problem with that wound healing and setting that person up for an amputation. So when topical antimicrobials fail, and they will fail, the diagnosis of infection in a hard to heal wound is a clinical decision based on the signs and symptoms of infection and prolonged non-healing. The decision is made. We're going to need some antibiotics, some antimicrobials. So the antibiotics are prescribed initially empirically, and the wound is debrided and cultured at that time. That culture and sensitivity test is sent to the lab to then guide the antibiotic therapy, especially if that patient hasn't responded to the empiric treatment that the provider gave, the systemic antibiotic that the provider gave. And remember everyone, some wounds will not heal due to that patient's health status. These wounds need to be addressed. They need to be documented as palliative wounds and have conservative treatments versus advanced wound management treatments such as negative pressure or cellular and matrix products. So this is an infected sacral wound, and this wound does require systemic antibiotics. So we don't hold systemic antibiotics. We start our topical immediately, and if you need systemic at that time, you go ahead and, because you know your signs and symptoms, and look at the lab work. That's important. So in summary, stalled, hard to heal, or worsening wounds, you want to implement wound hygiene safely in any of the care settings. You want to consider biofilm at all stages of healing and in all wound types. It's invisible to the naked eye and a key barrier to wound healing. Do not wait. Treat the wound topically now. Proactively address this. Proactively manage and perform wound hygiene appropriately. With your etiology specific supportive care, that's taking care of the whole patient there. Proactively monitor, not reactively monitor. Look every day, every shift in some cases. Determine the intensity of wound hygiene at each healing stage or type of tissue. Reassess that wound in that patient at every dressing change and refer to other specialties. Maybe they need to go to see infectious disease or cardiology or dermatology. Acknowledge that a hard to heal wound remains hard to heal until closure. So practice some level of wound hygiene at every assessment on all wounds until closure. And remember, some wounds will not heal. Watch carefully for when the wound should transition to palliative wound care. Any questions or thoughts that we need to talk about? And we just want to mention, because we're right here at the end, next month, we're going to do the endangered heel, the one pressure injury we should never, ever have. But we do. We have a lot of them.
Mhm.
All right, Miss Jacqueline, what you got?
One question here from Naomi. She said, are there any insurance issues for reimbursement for more than weekly debridements?
Are there any issues with debridement being done more than once a week? You do debridement when you have the dead tissue in the wound bed. And slough comes back. And slough, by the way, has a lot of bacteria in it. Slough can come back in 2 or 3 days. And so if you need to do it 3 days later, then you do it by what the patient needs. I'm not sure at this point if you are over debriding and the wounds don't need it, it will catch up with you from a CMS perspective if you can't show in the documentation that you needed to do that second or third debridement that week. So just be sure that you're documenting and what you see, what you debride. If it's there, there's, as far as I know, there's nothing wrong with that. Okay, thank you. That was a good question.
Sure. And that looks to be it from the questions. If anyone else
Oh,
has a
you know
question.
what, I do see something. CMS is a different thing. They might
Mhm.
not reimburse you, But you're not going to be penalized because a wound needed debridement that CMS isn't going to pay for. If they're going to limit the number of debridement, that may be what they do to us, but you still have to decide, does that wound need to be debrided or not, no matter what CMS decides. And the reason that happened is because we were abusing debridement. And I say we, the collective we, our CMS wouldn't have pushed back on us with that. A few bad actors make it bad for all of us. So with that said, I want to say thank you. I hope I see you next month and go forth and do great wound care. And thank you for being here.